Yeah, so I think we recognise that although there are incremental and important advances in outcomes for patients treated with newly diagnosed AML with chemotherapy or transplant, that relapse is still a major problem. There has been progress for patients who relapse after treatment for FLT3 positive AML. The Admiral trial demonstrating a survival benefit of Gilteritinib over intensive salvage chemotherapy is really important. That reinforces the importance in this subgroup of Gilteritinib as an effective salvage therapy, potentially moving to a curative transplant. It reinforces the importance of molecular analysis of all patients at relapse in case they've got an emergent FLT3 mutation. And I think we're looking at an environment in which we also, using new drugs such as venetoclax, will have more effective salvage regimens. So the FLAG-IDA-VEN data from the MD Anderson looks really promising in terms of CR rate and then moving again to transplant. So I think that's a really exciting area. The other area that I think is moving is what do we do in patients who relapse post-transplant? I mean, the first most important thing is, can you think of strategies that prevent relapse? And the Impact Network is delivering 2 studies, COSI and Amadeus, that are asking pivotal questions about how do we modify the conditioning regimen, how do we modify potentially pre-transplant MRD, and how do we deliver effective maintenance for patients transplanted. And in that context, the data from Germany, Burkert in JCO last year, showing that maintenance with Sorafenib in FLT3 positive transplanted patients led to improved survival is important. But in patients who do relapse, we need to think about how we employ new therapies. FLT3 inhibitors such as Gilteritinib can be important salvage post-transplant, but we also need to think about how we use venetoclax-based regimens. Critical thing is to get them back into remission, then you can get DLI in or possibly use a second transplant. So I think the totality of the field is at last moving, and I think finally the most important observation really would be that we have to embed molecular analysis, patients that relapse, but we also have to embed translational studies that teach us about clonal structure, teach us, for example, particularly in people who've had venetoclax-azacitidine regimens, what are the molecular basis of relapse? We're still not clear about that, because that drives the design of new therapies.